Hi, everybody. This is going to be the laboratory portion from Thursday of last week, which would have been whatever date it was, whatever Thursday was, the second. Okay. And this is where we're working on. We had finished part A, and this is really the breathing part of the program. I had recorded this earlier, but there was a problem. And so I'm going to be doing it again. And this is really more about the physiology of breathing than anything else. And it's fairly straightforward from a lab perspective. We know the air goes in and out, and it's really based on pressure. To summarize, there's a negative or suction pressure in your lungs. They're constantly inflated. And there's a variety of reasons. There's air residually in the lungs to keeps them inflated. There's a certain amount of surface tension from the moisture on the lining of the lungs and the lining of the wall of the pleural cavities or the pleural chambers, because remember, they're sealed. And basically, we're at effectively one atmosphere pressure with some variations weather-wise. And because of this suction pressure, there's always a constant little bit of flow into air. And all we do is we base it on something called the ideal gas law, which very simply stated means when you have a closed chamber, pressure and volume have a constant relationship. Pressure goes up, volume goes down. Volume goes up, pressure goes down. When the lungs inflate a little bit, they increase their volume, pressure goes down, creates more suction pressure. Not a lot. We're talking about a few millimeters of mercury. So if 760 is one atmosphere where we basically are, and it goes to 754 or 753, that's, you take a deep breath, that's basically what it's doing. And you're pulling it in. So we'll look with regard to that. So this is when they're talking about the pressures, this is basically what you're seeing. Not a whole lot else to it. And so, and there's a certain amount that fluctuates with breathing, as you can see, and they go through a lot of this. And it's usually on average about 4 millimeters of mercury based on the residual air that's in the lung that stays there, and that little bit of moisture that keeps them continuously inflated, and just the nature of the anatomy. And fluid is constantly removed. And the whole idea is we don't want to have any extra fluid or alterations of pressure because it's just such a fine balance. 4 millimeters of mercury isn't a whole lot. And so the lung could collapse. And that's what happens in an auto accident. Before we had airbags, and even with airbags, it hits so hard it can cause effectively a rupture in the lining, and that allows air to rush in from elsewhere and collapse the lung. Fortunately, we have two separate uh, systems. Effectively, the lungs are two separate chambers, so if one collapses, the other one can still work. But you do have to very rapidly suck the air back out, because once the lung collapses, it kind of adheres to itself, kind of sticks together. And the longer it sticks together, the harder it is to inflate. That's the big problem when we have injuries to the lung or infections, things that damage that and cause areas to collapse. They're very, very difficult to reinflate. And so we rely on certain things. Thankfully, we have a lot of elasticity. So that's good because it makes it easy for us to exhale. We don't have to expend any energy. It's bad because the lungs have a tendency to collapse. But the surface tension does have it, even has a little bit of pull because there's kind of moisture inside the lining, the surfactant. But the difficulty with that is it does tend to reduce the size of the alveoli so they don't stay overly inflated. So we have to have other forces, and that's has to do with the negative pressures and some of the surface tension on the exterior, so the surface tension interior and surface tension exterior. So all of those things play a role in it. And then you can do these calculations, and we're not, and they're showing them to you here. We're not going to go over it. And with a fancy name for a collapsed lung is called atelectasis. Now, that's typically what happens when there's pneumonia, when there's obstructive pulmonary diseases. Those are the kinds of things that can do that. What is the common cause traumatically is called pneumothorax, or sometimes tension. Tension just means pressure. Pneumothorax, wounds, a rupture, and you basically have to suck the air out. It's called putting in a chest tube. You have to reinflate it. That is the lung by sucking the air out, and then gradually that lining will heal, and you can remove the tube, and it will eventually heal over completely. And that's done a lot. Okay, good. We used to see that all the time in the emergency room when there was big traumatic things, and certainly other stuff like gunshot wounds and stab wounds. That's a big problem as well. So when you talk about ventilations in air in and out, inhaling and exhaling, and again, the whole idea is this constant relationship. It's called Boyle's law, and it basically is the same thing as the ideal gas law. You have one set of numbers and another set of numbers. So when you're inhaling and exhaling, but if you compare them, the relationship between pressure and volume. So as the volume goes up, pressure goes down, or as the volume goes down, pressure goes up. So they remain equal. We call that inversely proportional. And so, how do you breathe? Basically, the only time you utilize energy is when you inhale, and you're lowering your diaphragm, so using that muscle actively, expending energy, and you're firing your external intercostals. They're the ones that are pulling the rib cage apart, and that creates an increase in volume. So those are the big muscles. So the diaphragm flattens, and the intercostals kind of pull the chest up and out, and bingo. Next thing you increase the volume, reduce the pressure, and that's going to bring air into the system. And so basically, they're going through the numbers that are there. And you can see it lowers it maybe about 6 millimeters of mercury. So it drops it just enough to make sure that air comes in. Now, if you have to take a deep breath, now you have to use internal intercostal muscles, neck muscles, pectoralis muscles, back muscles, all of those types. And I think when you're really pushing your breathing in and out, let's say you're doing a workout, or even afterwards, you can almost like you're expelling carbon dioxide and bringing in oxygen. You're using extra muscles, and this is one of the reasons why people with breathing problems are so fatigued, because in order to get air in, they have to use it's not effortless like for us. Hopefully, it has to do a lot more than that. So that's something we see. And you can go through all these and you don't want to. And so normally you just have to relax, and the elasticity and the muscles going back to normal will cause that change. And basically that'll be the expiration, unless you have to like blow out the candles or strain and push. Now you have to use extra muscular activities. And that's really what this is all about. And so we measure these things, and we were actually going to do this in lab. This is we basically are measuring it from breathing in and breathing out, breathing in and breathing out. It's got a fancy name. It's called the tidal, TIDAL volume, on an average 450 to 500 milliliters, about a half a liter. That's the tidal volume, and we use that. And so we have a device that we can use. It's called a respirometer. We have one that's upgraded because we're going to see it graphically, electrically, with the technology we'd have in the old days. We still have a device in the lab where it's basically a drum that displaces water as you blow in and out. And effectively, it calculates that in a variety of different ways. So we have other things that cause air to move in and out. These are called non-respiratory air movements. And the things you're so crying and sneezing and coughing and laughing and all that kind of good stuff. And so that's not necessary. And a lot of it's reflex, certainly with sneezing or coughing, with particles or irritants or things like that are there. And so they really are not designed to move air in and out. And how the factors that influence is there's anything blocking the way, resistance, the surface tension. And that means we have to have a sufficient amount of lubricant or surfactant to reduce that surface tension, and inherently the stretchiness of the lungs. Think of the lungs as a balloon. And if you bought a balloon and were blowing up for a little kid's birthday, you'd stretch the balloon first. You're basically trying to increase the elasticity or decrease the resistance in the balloon. That's really what compliance is, the inherent stretchiness that's there. And then you can go through all the numbers, and we're not going to do that. But you can see the big deal, just like it was in blood vessels where we control blood pressure. This is the area where effectively we control breathing. And those are when the medium-sized bronchi, there's so many of them and they're wide and they don't collapse. But as soon as they start to get smaller, working their way down, all those 23 orders of branching, and once there's the smaller they get, now we begin to increase resistance. And that's what occurs with this. So it becomes more strenuous, more difficult. And when they're really constricted, allergically with asthma or with particles or uh, any type of disease entities a la COVID. Those are the kinds of things that cause respiratory distress syndromes and then in even respiratory arrest where the lungs just stop functioning. And frequently, particularly with allergies and asthma or anaphylactic shock, which we talked about in the immune system aspect of the program, that's where the epinephrine comes in because it specifically dilates the bronchioles. You probably had it in autonomic nervous system. They're called beta 2 receptors, and epinephrine targets them. Here's the surface tension. As you can see, liquid is attracted to liquid, and basically, water has that very high amount of it, and it coats the alveolar walls and it coats the lungs, and so it tends, and so even though it might have a tendency in some instances to collapse, some of that surface tension is going to pull on it. Some of it, as particularly as we move our air in and out continuously as we do as we breathe, it tends to be an important part that's there. And we utilize the surfactant to limit this. So the surfactant, which is like a fatty and protein compound, reduces the amount of surface tension within the fluids that kind of line the interior of the alveoli, preventing it from collapses. The alveoli are type 1 cells. The cells that make the surfactant are type 2 cells. They don't really become active till relatively late in gestation. That's why there's an insufficient amount that sort of by about 26 weeks, about the start of the third trimester, that's when we have viability. Now that we make surfactant, we can go a little bit earlier, and here's this infant respiratory distress and fetal lungs and not present until at least until the last 2 months of development. And that's probably a I think you could make an argument that, under favorable conditions, it could even be a little bit sooner than, and particularly since we make the surfactant. But that's one of the big problems with preemies is respiratory distress stress syndrome. My middle one was born about 4 weeks premature and fortunately did not have really any respiratory difficulties. He had others, had some blood incompatibility difficulties, things like that. And did spend some of his early time in intensive care, unfortunately, first couple of weeks. So there's natural or synthetic surfactants that you can be used. There's breathing devices, and mechanical ventilation is really a problem because the lungs don't develop as well as maybe they should. You have to use it early on. Here's the compliance. So how stretchy they are, how distensible is the fancy term. And normally it's pretty good. So it means it's easier to expand. They're very compliant. As you get older, particularly elderly people, you begin to lose this a little bit. So, and that can come from inflammation. It can come from smoking. It can come from infections. Yeah, I mean, there's just so many different ways. And unfortunately, it does make it harder for people as they get older to breathe. And it would have been yours truly if I had continued to smoke. And then all of this has to do, again, the costal cartilages, the cartilages between the sternum and your rib cage are a problem. Intercostal muscles, if they're paralyzed for whatever reason, deformities in the thorax, and all of this, and really the sort of the focal point of this little discussion is something we were going to do in lab, and I was going to give you the same presentation, and that's these respiratory volumes. And these are the tools we use, and with the device that I'll show you in lab on Thursday, when we begin to look at something called vital capacity. The first volume is the tidal volume. Now, if you take your deepest breath, you can always bring in more when you forcibly inhale than you can expel when you forcibly exhale. That big deep breath is called the inspiratory reserve volume. The biggest amount that you can exhale is the expiratory reserve volume. If you take your biggest breath in and blow it out as hard as you can, we call that the vital capacity. And if you're blowing it out as hard as you can, the forced vital capacity. And so we add up these different volumes to make capacities, and we're going to use a spirometer because we don't have to worry about the one with the water and the electron. We effectively have this device, and we have sterile units that you're able to use and demonstrate with. So the tidal volume in the air in and out, and your inspiratory reserve for most of us is a couple of liters. That's a lot. So you can inhale 4 or 5 times your normal what you would normally breathe in and out, but maybe only twice that extra air to blow out the candles. And believe me, as you get older, it's harder. And you always have to have a little air. We call it the residual volume. And there's a formula based on your height and your age and your gender and chest measurements and like measurement from, let's say, your spinal area in and around that. So there's all sorts of parameters you can use, and there's a formula you can plug it in. You actually can figure out what your total lung capacity is and then see how these numbers play in. So when we start talking about the total lung capacity, it's all of these. It's the tidal volume, your inspiratory reserve, your expiratory reserve, and what's left in. If you just have vital capacity is tidal volume, inspiratory and expiratory reserve. So think of that. Other than the air that's always in the lung, that's your vital capacity. And so you have some functional capacities on the inhaling side and on the exhaling side. And this is really what the chart looks like. Normal in and out, tidal volume, deep inhale, big exhale. And if you take the distance from the deepest part of the inhale to the last part of the exhale, you get, and that's the vital capacity. And when we force it, we really try to max it out and see how big it can be and how rapidly you can get rid of it. And you can see in most people, they leave a residual volume around a liter, maybe a little bit more, depending on it's from a measurement standpoint, they might actually be able to get out more, but measuring wise, and it's not the easiest thing to do when you have to force it out for a lot of folks. And so again, these are the volumes, and when you add certain volumes together, you get these capacities. And typically men, larger frame, more so than women, but again, there's some variation based on the frame, a small man versus a larger woman, etc. So you can see the total capacity, probably in women, maybe it's 70-80% of the typical male. So the numbers are a little bit less. But again, that's figure outable. So it's very much proportional. So understand that even normal breathing, there's a lot of air that's in there. We call that anatomical dead space. It's not being used. Now, that's part of this residual volume. So a small part of the residual volume is we really appreciate with almost every breath because it's really just air that's designed to keep the alveoli expanded, if you want to think of it that way. Space occupied, and there's other stuff, okay? Space occupied by non-functional alveoli, if there's been damage, pneumonia, things like before. And so we look at these kinds of things. So not every aspect of your lung is working 100% perfectly, probably better when you're younger than when you're older, and you kind of add up the total dead space. So what's this all about? It's all about two things. It's a way we diagnose whether somebody has what's called an obstructive disease, a blockage, tumor, asthma, those types of things, or they have a restrictive disease, meaning they are unable to exchange oxygen and carbon dioxide satisfactorily. So if there's resistance, we look at any of these things, and what happens is it's almost like you're working harder, you're sucking in air, and what you tend to do is overly inflate your lungs. So it's almost like a bloating. In the old days, because they didn't get a lot of oxygen, we call them blue bloaters because they kind of they didn't look healthy and healthy looking skin color. If anything, it was a little more carbon dioxide, so we got sort of on the bluish, but then they typically had big chests. And restrictive reduces the total lung capacity from a variety of diseases. Tuberculosis, more common older days, so it's making somewhat of a comeback. Environmental problems, things, bad stuff in the air, environmental pollutants, nasty types of things can do that. And certain emphysema kind of overlaps both of these, by the way. So all of these factors decline, okay, because the lung just doesn't work the way it's supposed to. So even though you can get the air in and out, you just don't have enough functional space to do adequate exchange. That's where so it restricts the ability to exchange oxygen and carbon dioxide. So what we do is we take your deep breath and blow it out as fast as you can. We measure the volume. And so that forced vital capacity should be roughly, for most of us, the ones we measure around here, because it's not the most accurate way of doing it, probably around 3,000 milliliters. So three to 3.5 liters. I've had more in the fours and things like that because it's not the easiest thing to do because you have to clips on your nose and have to make a tight seal on your mouth. And it's not so easy to do. And you should be able to blow it out 80% of it. So if it's 3 liters, you should be able to blow out 2.4 liters in a second. So we call it the FEV1, or the amount of air expelled in the first second. So 75 to 85%, that's the range that's acceptable. Obstructive disease patients can't do it. There's a blockage. Either there's something in there that's not allowing it to come out quickly. Restrictive diseases can easily exhale it, even a greater amount. The trouble is that vital capacity is much lower. So, we'll do that, and we'll try to take a look at it in the lab. Just like your cardiac output, we have something called the minute volume or minute ventilation, roughly. And again, it's going to be about the same amount as your cardiac output, because you should be oxygenating as much, an equal amount of oxygen and carbon dioxide exchange as blood that's going to have to be reoxygenated. And we can increase it greatly. Okay. And so we look at the rates here in the individual alveoli to make sure things are effective. And it's very interesting. So we look at how much you're moving in and out, how frequently, and we have to take the dead space into occurrence, because the dead space is constant. Okay. The easiest thing to do is not breathe faster, but to breathe deeper. And if anything, breathe slower. And that's what you're going to see, is that the problem is when people are hyperventilating, they're doing rapid, shallow breathing, and they're making themselves worse because they're not getting enough oxygen, as opposed to, which you always will tell a patient, take big, slow, deep breaths, and you really oxygenate. And this is the chart. So normally we have that dead space, typical tidal volume, typical respiratory rate. So in that 20 breaths per minute at 500, we can get 10,000, 10 liters of air in. 7,000 is good because we have 70%, because we can't get rid of that. So we're basically have 350 milliliters of usable air every time we do it. But if we're doing it too fast, let's say we double the rate and we have the volume, rapid shallow breaths, we're still going to get the 10,000 in, but each one of those breaths only has 100 milliliters of use, and even there's 40 of them. Now our efficiency is 40%. But if we take shallow breaths, big, try to double the volume in and halve the number, we're still going to get that 10,000. But again, because the dead space is only 10 times 150, it's 85% more efficient. And so that's really, really important. And then we look at this with all the gas exchanges, and we'll take a look at these in lecture. Thank you. Hold on. Hush. And that'll conclude this, and we'll move on to the next thing shortly. Ignore the fact that I'm doing this at home and we have interruptions. Thank you very much.